Hello, everyone. Welcome to the workshop, Managing Sleep Challenges After Transplant. It is my pleasure to introduce to you Dr. Dave Balachandran. Dr. Balachandran is professor in the Department of Pulmonary Medicine at the University of Texas MD Anderson Cancer Center and the medical director of the Sleep Center. His research focuses on sleep disturbances in cancer patients and interventions to address them. Please join me in welcoming Dr. Balachandran.
Hello. Thank you so much for taking your time to join us today. I'm very excited to give this talk to you about managing sleep challenges after transplant. We have had a sleep program here at MD Anderson Cancer Center for about 15 years, so we've been able to gain some experience with these challenges, and I look forward to discussing that with you today. So sleep and cancer is a fairly broad issue, and I like to think about it starting with what people bring to their cancer diagnosis and their stem cell transplant or their bone marrow transplant. And obviously there's a lot of patient-related factors that impact the type of sleep disruption they may experience, and these include aging, pain, their experience with stress, their experience with sleep hygiene, other medical conditions and medications that they take. And then, of course, cancer itself and therapies related to cancer, such as bone marrow transplant, may also cause sleep disruption. There might be primary sleep disorders. We're going to be discussing some of them today that also may relate to sleep disruption. And unfortunately, once you have sleep disruption, it can impact many facets of your life. It can increase things like fatigue, anxiety, and depression. It can cause cognitive impairment. It can lower your pain threshold, so make you more sensitive to pain. It can cause hormonal imbalances, weight gain, and even other medical conditions such as high blood pressure or diabetes. Sleep and cancer is fairly prevalent. Sleep disturbance in cancer is fairly prevalent, and you can see in this study of over 1,000 patients that up to 44% of patients complain about fatigue, or they may report that they have insomnia. And in addition, almost 20 to 25% of patients with cancer take some sort of sleeping pill, some sort of sleep aid, either over-the-counter or prescription to help them sleep at night. So it's a fairly common problem. There are many different types of sleep disorders, and this is just a partial list of some of the ones that we may talk about today. Insomnia is the most common problem in sleep, both in cancer patients as well as specifically in cancer patients. And unfortunately, cancer patients and those with transplant have higher rates of sleep disturbance compared to the general population. Sleep disordered breathing or sleep apnea is also an issue, and there's actually links that show that people with insomnia and sleep apnea may actually be predisposed to cancer. So it's really important for us to try to understand these sleep disorders, what they mean, and how they impact our patients. So as I mentioned, sleep disorders are more common in cancer patients, and in fact, insomnia is 3 times higher in cancer patients than non-cancer patients. So again, the burden of disease or the burden of disturbance is more challenging in patients with transplanting and in cancer in general. These are some of the symptoms associated with insomnia. Some of you may have experienced this yourself. Insomnia is defined as difficulty falling asleep and difficulty staying asleep. And oftentimes, because of insomnia, the sleep does not feel refreshing in the morning, and you feel more tired and fatigued during the day. Insomnia can cause significant distress and also daytime impairment because you don't feel refreshed, you don't feel rested, and you have trouble doing the things that you'd want to do. Pharmacological therapies, such as sedatives and hypnotics, are often prescribed, and these themselves can have problems. They can make you feel groggy in the morning. They can increase the risk of falls. So some of these things that we use for treatment for sleep disorders can also be problematic. And therefore, what we really try to do in our center and in centers around the country is to really stress something called cognitive and behavioral therapy as a treatment for insomnia, because it's much safer than pharmacological therapy. And we'll discuss some of the tips that you can do at home to help yourself sleep better in a few slides. I wanted to talk a little bit before we get to that about some of the factors that contribute to insomnia. And as I mentioned, there's some factors that happen even before cancer, before stem cell transplant, and those can be related to aging. Some people are just more hyperarousable. They're just a little bit more sensitive to noise and different things that happen at night and just wakes them up a lot faster than other people. You can have a family history or a personal history of insomnia that may carry on after your cancer diagnosis or your stem cell transplant. And you could also have psychiatric disorders and adjustment disorders related to the cancer diagnosis that can also predispose you to developing insomnia during your cancer journey. There are also precipitating factors, surgery, long hospitalization. The average stem cell transplant requires about a 25-day hospitalization, and that can be very disruptive to sleep and have very long-term effects. Chemotherapy, nausea, vomiting, steroid therapy are some of the things that are associated with stem cell transplant, also can contribute and precipitate insomnia. Hormonal therapy, especially if you're on some sort of hormonal therapy that's suppressing normal hormonal function, that can cause hot flashes. And then, of course, pain associated with cancer or therapy and delirium associated with cancer or therapy can also precipitate long-term sleep problems. And then there are the perpetuating factors. And these are really important to understand because this is really where we can intervene and try to make things better. Over time, when you develop insomnia related to your cancer, what can happen is you start developing habits that make the insomnia worse. And these include spending more time in bed, having irregular sleep-wake cycles, sleeping during the day more, sleeping less at night, increasing your napping or more frequent naps, and developing poor sleep hygiene. We're really going to focus on what sleep hygiene is and how we can impact that. And we can also start to develop faulty beliefs and attitudes about sleep that can make it really hard to calm down at night, reduce anxiety, and actually help yourself fall asleep. And we start to develop unrealistic sleep expectations. We think that if I go to bed, I'm going to fall asleep right away and I'm going to wake up at a certain time. That may not be always realistic in every circumstance, and we start really getting anxious when those things don't happen, and that anxiety can actually precipitate more insomnia. There can also be faulty appraisals of sleep disruption, and what I really mean by that is we tend to attribute different things to the sleep disruption that we have that may not actually be the actual cause. We just tend to focus on them, and it's really hard to get past those. We misattribute the lack of sleep to all of our problems during the day, the bad conversation I may have had, the feeling tired all the time. It may be more than just sleep, and we may miss other attributes. So it's really good to keep a whole holistic approach to saying why you may have fatigue. Maybe is it anemia? Maybe is it a hormonal imbalance? Maybe is it something else that's medical or psychological that's contributing and not just sleep? And then we may have misconceptions about why it's insomnia, the etiology of why insomnia occurs. And these faulty beliefs can really be damaging, so it's really important in the cognitive portion of cognitive therapy to understand these expectations and misattributions and misconceptions to try to get a handle of that so we can substitute more positive ways of thinking about our sleep and what we can do to make it better. So here's some of the options for sleep, and we have a few slides on this, but they're kind of broken down into these two general categories. There's non-pharmacological therapy and pharmacological therapy. And the non-pharmacological therapy is some of these things that I was just been talking about, improving sleep hygiene, and we're going to talk a little bit more about that. Getting involved is needed in a good program of cognitive behavioral therapy, and there's different ways to do this. You can go to a therapist. There's online programs now that you can do, and there's other handbooks and other materials that you can find from the National Sleep Foundation and other good sources that can help you with that. Sometimes we use light and melatonin, and we have a lot of studies here at MD Anderson looking at that. And there's some really brilliant work on daytime exercise, daytime yoga, Tai Chi, other ways of approaching what you do during the day to help you sleep better at night. And then, of course, there's this multi-billion-dollar industry out there that provides sedative hypnotics. You've heard the names: Ambien, Lunesta, Sonata, Balachandran. There are all these wonderful drugs that are very good for perhaps the short-term treatment of insomnia, especially right after a stem cell transplant, but really for the most part, don't work so well in the long term and can have a lot of side effects. Sometimes if we find that depression or something else is causing the insomnia, antidepressants can be very useful. And also there's stimulant medications can help with some of the daytime fatigue and the daytime sleepiness that we sometimes use, and that can actually help promote, paradoxically, good sleep at night if you have more activity and feel better during the day. So let's talk a little bit about sleep hygiene, because this is really something that you can do at home, and there's this wonderful link to from the sleepfoundation.org that you can look at that has even more information on this. But I just want to give you some of the highlights. Finding pain-free mattress, finding a pillow that works for you. Everyone's a little bit different. You may have a catheter in a certain area that you don't want to put pressure on. All of those things. Find a way of sleeping that you feel comfortable in. Keeping the temperature on the cooler side can really help promote sleep. Cool temperatures actually do promote sleep. Finding comfortable sheets and blankets that you can modulate that temperature with can be also very helpful. Light is something that we talk about a lot because light actually activates the brain. It's actually a signal for us to be alert and awake. And it's really important to sleep in a dark room to minimize excess sources of light so that you can sleep. And I would add to that, bringing your iPad or your phone or your laptop or having a TV in a room is also a source of light. And I know a lot of the technology now is trying to block out some forms of light. There's a particular spectrum of light called blue-green light that is really activating, that actually promotes wakefulness and interrupts sleep. And a lot of our electronics now have mechanisms. You've probably seen day mode and night mode where they block out some of that blue-green light. But honestly, I think the best advice I can give is to avoid all of those kinds of activities, whether it's with a phone or a laptop or a device of any sort from your bedroom. If you need earplugs or a white noise machine to drown out exogenous or outside noise, that could be very important. And some people find things like aromatherapy. Find the fragrance that works for you, that's not going to make you nauseous, that's not going to cause problems. But if that helps you, by all means, try it. Here's some more rules for good sleep hygiene. Keep being consistent. Your brain really likes consistency. It wants you to go to bed at the same time every night and wake up at the same time every morning. And that way, having that consistent routine will help really structure your sleep at a certain time and help you fall asleep better. Having a consistent bedtime routine, whether that's reading, praying, meditation, whatever that might be for you, whatever helps. Doing that, finding a way to settle down, having, if you need to, a cup of milk or something that helps you fall asleep, whatever that might be, being very consistent, almost creating a ritual is the term that we use for that sometimes. Having a bedtime ritual or routine can be really useful in telling your brain, this is the time to wind down, this is the time to fall asleep. Unplugging electronics, I can't stress that enough. Very important to do, and we already discussed a little bit why that's important. Winding down, doing things, avoiding things that are very alerting, avoiding that movie or that that conversation that's really going to cause anxiety or provoke a lot of alertness. Exercise, if you're going to do any, this is the time to do not heavy exercise, but stretching, those kind of things that may help you. Dimming the lights even before you turn them off completely can help, because that will help with melatonin, your own melatonin secretion from your brain. That can also help you send that signal to your brain that it's time to fall asleep. And then create this mental connection between being in bed and sleep. Very important. Again, we want to use the bedroom only for sleep. We don't want to use it for active activities such as working, reading for a long period of time, watching television. If you can take those outside the bedroom and reserve your bedroom environment for sleep, that's going to help you fall asleep. And then this last bullet point is very important. If for whatever reason you're in bed and you're not falling asleep, and you're starting to look at the clock and starting to worry and being anxious, like, why can't I fall asleep? I really would like to sleep now. It's really important to get out of that bedroom environment, do something relaxing, go back to the stretching, the reading, the relaxation exercises, the soft music. Do those things until you're ready to fall asleep again, and then go back to that environment and try to fall asleep. You may end up doing this a few times, but over time, you will send that message to the brain that the bedroom environment is for sleep and not for these other activities, and really help your brain make that association with your bedroom environment and sleep. Here's some really good daily habits, because if you think about sleep and wakefulness, they do work in a continuum. The more alert and more awake and more you do things on a routine during the day, it's going to set you up for more success to sleep at night. And one of the things, the best things you can do is getting that early morning light. I know we're coming into summer in the Northern Hemisphere, and for those of you in the Northern Hemisphere, morning light is going to be very important this time of year, and substituting that with whatever bright lights you have in the wintertime for those of you who are in more northern cities is also very important. Getting that early exposure to light kind of tells your brain this is the time to be awake, and then shutting off those lights at night tells your brain it's time to fall asleep. Being as physically active as you can manage within the parameters that your doctors and nurses have provided you is really important. The more active you are during the day, the better off you're going to sleep at night, and that always seems to work in a nice continuum. If you can avoid naps, that's wonderful, but if you can, try to keep them short and try to limit them to the early afternoon rather than later in the afternoon or evening when they may interfere with sleep. The more sleep debt that you pay off during the daytime, the less sleep debt you accrue, that'll help push you. Smoking is very important. Nicotine is a stimulant, and it can interrupt sleep. Avoiding alcohol later in the evening is important. Alcohol is a sedative, but it is a very short-acting sedative. That means that it may help you fall asleep, but when the alcohol wears off in 2 to 3 hours, it actually will alert you. And actually that withdrawal from alcohol is alerting and actually can wake you up for sleep and disrupt your sleep. It can also contribute to things like sleep apnea, which may make your sleep quality worse. Avoiding caffeine in the early afternoon, in the late afternoon and evening is important. The half-life, or how long caffeine works, can be up to 8 to 12 hours. So the caffeine can still be in your system even 8 or 12 hours after you drink that last cup of coffee or that last soda. And so it's very important to try to avoid caffeine. Avoiding heavy meals at night can help. And again, creating this association between your bedroom environment and sleep. So using your bed only for sleep and sex is really important as well. I want to touch a little bit on cognitive and behavioral therapy as a treatment for insomnia because it's very important. The rationale for CBT is that we have negative thoughts related to sleep that we develop. We also feel differently about our sleep. We start getting anxious about it, and that affects how we think about our sleep. And then how we feel and how we think about our sleep affects our behaviors, and that prevents us from falling asleep. So cognitive behavioral therapy is trying to take that thought and emotion and create new behaviors that promote sleep. So it's redirecting our negative thoughts towards sleep to more positive thoughts. It's redirecting our negative emotions towards sleep to more positive emotions and creating that more positive behavior. Following these sleep hygiene tips that we just went over will be a very strong way of doing that. And study after study in cancer patients and in non-cancer patients has shown that CBT, cognitive behavioral therapy for insomnia, is as effective as pharmacological therapy for insomnia. And the effects of CBT are longer lasting, and the benefit in terms of safety is much higher. All of the sedative hypnotics have been associated with things like cognitive dysfunction, poor thinking, grogginess in the morning, and even to the point of deliriums and falls, especially in the elderly. So we really want to use pharmacological therapy for insomnia very carefully. We want to select those patients very carefully and only use them in the short term, maybe right after admission or during that long hospital stay. They may have an important role, but as soon as that role is accomplished, we really want to move on to the sleep hygiene and the CBT-I, cognitive behavioral therapy for insomnia, as our mainstays for treating insomnia. Light and melatonin are being used more often now to help regulate sleep. Melatonin as a drug used in small doses can actually help promote sleep by retraining your circadian rhythms that may become off cycle a little bit because of a long hospitalization or because of a stem cell transplant. And light, as I mentioned, from certain screens, especially that blue light, can actually reduce that production of melatonin, so it's really important to avoid those before at bedtime. And using light therapy in the daytime, especially in that early morning, can really promote sleep during the day. And it kind of builds with this slide I have here on yoga and exercise. If you do those activities in the early morning, you're almost getting a double whammy. You're not only getting light exposure, but you're also getting another alerting system going, which is that physical activity. And that can really be a wonderful mechanism to say, this is the time to be awake. And on the converse, relaxing and turning off the lights at night is a really good signal to say time to shut down, time to go to sleep. So they kind of work hand in hand. So regular, moderate to vigorous exercise can reduce the time it takes to fall asleep at night. It reduces daytime sleepiness, and it also helps modulate your weight and other things that may cause things like sleep apnea, which also affect your sleep. We'll talk about that a little bit more. These are some of the more common, and I'm using the generic names here that you might see: the sedative hypnotics, the pharmacological therapy for insomnia. Zolpidem is Ambien, and Zopiclone is Lunesta, Suvorexant is Balsamna. So there are all these different medications that you may see on the market. You see the ads on TV. They do have a good role for short-term therapy, but none of them have been shown to promote sleep in the long term, after 6 months or certainly after a year. So we really want to think of them as a short-term solution for an acute exacerbation of insomnia. Sometimes antidepressants can be helpful, and really the side effect profile for some of these drugs can be pretty significant in terms of increasing grogginess, decreasing your mental abilities, decreasing and increasing rather your risk of falls and delirium, which are really important things to consider. I do want to spend a little bit of time that we have remaining talking about some other sleep-related disorders that do affect patients with bone marrow transplant and cancer. Movement disorders, especially there's something called restless legs, and the reason I bring this up is many patients with cancers are anemic, and there is a relationship between iron deficiency anemia, B12 deficiency anemia, and the syndrome of restless legs. And then what restless legs is this unpleasant, tingling, creeping feeling or nervousness in your legs that you may actually think is neuropathy related to some of the chemotherapy agents that you had, but it might actually also just be this restless leg syndrome that has other treatments. So if you do have those kind of symptoms, and they usually happen at bedtime, so they can interrupt with sleep and cause insomnia, it's a really good thing to think about, like maybe say, hey, could this be restless legs, and maybe could I get treated for it and make both my sleep and my restless legs better. There's also another limb movement disorder of sleep called periodic limb movement disorder of sleep, and this can happen in cancer patients, especially if they've been on certain chemotherapeutic drugs or have stem cell transplant or have B12 or folate deficiency. We've seen it in all of those, and therefore, another thing, if you're having a lot of movement at night that's new after your bone marrow therapy, it may be something good to talk about because a sleep study may uncover this disorder that also has treatments. And the treatment for these are directed at either neuropathy or they're directed directly at the restless leg syndrome with certain medications that are also used for Parkinson's disease. So let's move on a little bit. I do also want to talk about another sleep disorder, which is hypersomnia, which is another fancy way of just saying excessive daytime sleepiness, being really sleepy during the day. And that affects a lot of people throughout the United States and throughout the world, but it especially can impact patients with cancer and stem cell transplant. There is this diagnostic test we do in our sleep clinic, and we're bringing this into more clinics here at MD Anderson to try to screen for that daytime sleepiness, and it's available in many languages. This is actually kind of what a sleep study looks like if you're ever asked to do one, so I just wanted to kind of go over that really quickly. You can see the red and black at the top, and that's actually looking at the sleep stages. We actually cycle through stages of sleep. And when we say that someone's sleep is disrupted, what we're actually saying is that normal cycling through the stages of sleep is impacted, and you don't get as much deep sleep, and you don't get as much REM sleep. You may have heard that term, rapid eye movement sleep. That's those black boxes at the top are actually this patient's REM sleep, and we don't see as much of that. And when you don't have as much deep sleep and you don't have as much REM sleep, you wake up feeling less rested, and you feel like your sleep quality hasn't been as good. This patient actually here that I'm showing you actually has pretty normal sleep. But what's really interesting in this patient is we did this test called a multiple sleep latency test, and it actually showed that this patient had as much sleepiness, and this is after cancer therapy, as compared to someone with narcolepsy. That's a disease where people fall asleep all the time. You may have heard of it. And there's this association with certain cancer treatments with this daytime sleepiness, and sometimes we need to use stimulant medications such as described on this slide. These are some of the studies we've done here at MD Anderson and elsewhere that have been done primarily in patients with solid tumors by using stimulants to help prevent the daytime sleepiness, which can also help us sleep better during the night. So when you come into our sleep clinic, we actually assess for both of these things so we can get you on the right therapy. I'm going to move on a little bit. I do want to touch a little bit on sleep disordered breathing, because that is a sleep disorder that has this bidirectional relationship with cancer. What I mean by bidirectional relationship is that we know now that sleep apnea, there's some studies that show that it can increase the risk of cancer and also increases the risk of cancer mortality or cancer-related death, and that patients with cancer may be at risk of having sleep disorder breathing as well and other sleep disorders. So that's what I mean by this bidirectional relationship between the two. And what sleep apnea is the syndrome where people stop breathing in their sleep, or their sleep pattern is altered during their sleep, and it can cause things like excessive daytime sleepiness. And that can be problematic. And we usually diagnose that in the sleep lab, and we do sleep testing to find that, and we treat it with a device called positive airway pressure, or CPAP, is what it's more commonly called, to help treat the sleep apnea. I want to finish with an important topic that we spend a lot of time studying here at MD Anderson, and it's this role of circadian rhythms in cancer. And there are some studies in even bone marrow transplant that after a bone marrow transplant and that long hospitalization, that the normal rhythms that your body creates that tell you when you should be awake and when you should go to sleep are reduced, so that the signal that your brain gives you to fall asleep is decreased, and the signal the brain gives you to be awake is decreased, and it leaves people feeling less able to fall asleep at night and more sleepy and fatigued during the day. So it's sort of a double whammy. And then we spend a lot of our attention trying to figure out ways with light, with melatonin, with sleep hygiene, with cognitive behavioral therapy, with light and melatonin to try to restore those abnormal circadian rhythms so that we can get people back to where they are, where they need to be. With different cancers, and I have ALL here and chronic myelogenous leukemia, some of the most common indications for stem cell transplant. We find that there's gene alterations from these tumors that impact circadian rhythms. And so it's really important for us to try to understand this complex interaction between cancer and circadian rhythms so that we can try to devise strategies to improve that. And one of the things that's been studied quite a bit is this relationship between melatonin. Melatonin is this hormone that's made in the brain. It's governed by the circadian rhythms, and it's very closely governed by light. As I mentioned, the light from the iPad or the phone, or natural light from the room, or even turning on your lights up in your bedroom, all will inhibit melatonin. So that's why it's really important to keep that room dark at night. And we're actually sometimes, in some of our studies, giving melatonin to try to promote sleep and restore circadian rhythm, especially in patients who have identified have circadian rhythm disturbance. So there's studies that show that we can tailor this sort of treatment to improve outcomes. I'm going to move on here, and this is just a slide that shows that we can use things like melatonin and light therapy as a form of circadian therapy to try to impact sleep at night and promote sleep. And this is a recent study that we just published where we tried to combine all these different streams that I've talked to you about, the behavioral therapy that we talked about, the light therapy, keeping people's daytime schedule intact by having scheduled meals, having scheduled exercise. Again, everything we do during the day impacts how we sleep at night, and how we sleep at night can impact the day. It's sort of a continuum. So when we look at it, we want to think about it as a 24-hour cycle, and then by restoring that 24-hour cycle, improving the circadian rhythm, increasing that signal to fall asleep, and increasing that signal to stay awake during the day. And so we developed this study where we had different arms, where we used bright light therapy, we used melatonin, we used methylphenidate, and every patient was instructed in sleep hygiene and cognitive behavioral therapy, and we wanted to see if that improved their sleep, and we were able to show a significant improvement in their sleep quality, and it was as durable and as good as seen with pharmacological therapy. So again, I think going forward, this is really the strategy that we'd like to see used more to treat sleep disturbance in patients with stem cell transplant cancer. This combined therapy where we look at what's going on in the day, try to increase light exposure, try to increase exercise, schedule meals to keep that on a nice time frame, and then have that downtime routine at night, use melatonin if we need to, and improve sleep during it at night through sleep hygiene and those kind of things. So really using that whole 24-hour cycle to our advantage to try to improve sleep throughout the day and increase function throughout the day. If you were to come to our sleep center, these are some of the tools that we would use to evaluate your sleep. We would measure whether you may have a risk for sleep apnea. We measure your sleepiness. We measure your sleep quality. We measure your fatigue levels. We do a physical exam to look for other factors in your physical exam that may predispose you to a sleep disorder, such as sleep apnea, such as a high weight or BMI or a thick neck. We may think about doing imaging, especially of the brain, if we think there might be some circadian rhythm disorders. We may do pulmonary function tests to see if there's low breathing volumes at night that may impact your sleep. And lab studies, such as checking an iron count to see if you have iron deficiency anemia or a folate level. Those kind of things say, are you predisposed to things like restless legs, a periodic limb disturbance? So this is sort of our overall way of sort of evaluating a patient who comes to us with a sleep disorder so that we can look at every factor that may impact their sleep and so that we can address those individual factors to try to improve sleep. So I'll just conclude here so that we have plenty of time for questions. Sleep is really essential for life. Without sleep, we can't function. And sleep disruption, unfortunately, is more common in patients with transplants and cancer. And we know that if there is sleep disruption, that can precipitate and cause other symptoms, fatigue, anxiety, depression, insomnia. All of these things kind of work together. It's really important for us to be systematic and identify underlying sleep disorders so that we can impact each one of those to try to improve overall sleep quality. And I would really stress one of that third circle I have there, circadian. Thinking about sleep and wakefulness as a continuum, I think is a very important concept that I'll just try to reiterate right now. What you do during the day will help you sleep at night. So the more early light you get during the day, the more active you are during the day, the more you can schedule those meals during the day, is going to help you fall asleep at night. And then in the evening, you want to follow the same kind of rules. You want to stress that bedroom, that nighttime routine or that nighttime bedtime ritual. Then you want to be able to follow the sleep hygiene rules that we discussed. Some of those things will also help you during the day. And then if you're not falling asleep, getting out of bed, using the bedroom environment just for sleep. So what you do during the day can impact what you do at night, and how well you sleep at night can affect your function during the day. And when you do that, think about it as a continuum. You're helping potentiate those circadian signals to have a structure to your alertness and a structure to your sleep, which can really be beneficial. And I'll leave you with this fact of why we think this is so important is that we're finding out that how you sleep can actually impact tumor behavior and mortality. Further study is needed, but I'd like to think at some point we might be able to show that if you can sleep better, you will do better through your cancer journey and actually have a better quality of life, and that's really what our goal is in the end. So I'll leave some time now for questions, and thank you again for allowing me to join you today.
Thank you so much, Dr. Balachandran, for the wonderful presentation. We will now take questions. As a reminder, if you have a question, please type it into the chat box on the lower left-hand corner of your screen. The first question asks, how can I find a CBT insomnia specialist near me?
That's a great question. So you can find them in sort of unexpected places. I would start by talking to your oncologist, because there may be networks in your institution that they are familiar with, so that they can refer you to people that they understand and they have good feedback and a good relationship with. So I would start there. If that's not available, there are two websites that I would direct you to. One is the American Academy of Sleep Medicine, that's AASM, and I believe their website is aasmnet.org. And they actually have a list of providers who are board certified by the American Academy of Sleep Medicine in both sleep disorders as well as in CBT. And so I think those would be my two resources. I would, if you can stay within the system that you work with, there may be benefits in terms of communication, because I know we do a lot of back and forth with our therapists to try to understand what's medical and what's more therapy related, so that we don't miss anything. So it'd be good if you have that benefit of that. But I think both the National Sleep Foundation have resources, as well as the American Academy of Sleep Medicine can point you to providers in your area.
The next question is, does sleep quality impact rebuilding your immune system after a transplant?
Wow, that is a fantastic question. I can tell you what we know and what we do not know. So what we know is that sleep disruption impacts the immune system. We know that patients who have poor sleep quality have decreased immune function, and we have increased inflammation. So sort of the negative consequence of the immune system is inflammation that can actually cause more problems and more symptoms. So that we do know. Unfortunately, although we have some evidence, there's some good evidence with CBT, if you can believe it, that you can actually reconstitute some of that immune dysregulation and also improve that pro-inflammatory framework with sleep disruption. Now, specifically with bone marrow suppression that occurs with stem cell transplant and then re-engraftment, I do not think we have any data to suggest that improving sleep will impact that. But please stay tuned, because I think that's a very, very intriguing question, and I think we may be surprised that there is an impact. So I try to tell you what we do know, and what we don't know. So we don't know the exact answer to your question, but I think we have some signals to suggest that it may be important to look at sleep as a modifiable factor to improve immunity.
The next question, someone wants to know if senior citizens naturally sleep less efficiently than when they were younger. They used an example of waking up multiple times at night.
That is a great question. So if you recall one of the slides, I showed you the sort of the cycling between the stages of sleep, and I didn't really get into it very in detail because I wanted to spend a lot of time talking about insomnia and the sleep tips. But we do cycle through different stages of sleep at night. And in normal elderly patients, this is patients without cancer or transplant, but just patients without, and forgive me for using the word normal, but that's kind of the word that's used in the literature, not to suggest that people with stem cells and cancer are abnormal in any sense. But in the patients without cancer or sleep disturbance, without cancer or stem cell transplant, As we age, the cycling through those stages of sleep decreases. There is as a norm, there is less REM sleep and there is less deep sleep. So your ability to perceive your sleep as good quality sleep goes down. What also tends to happen in the elderly is sleep shifts. It actually what we call phase advances. So elderly patients get more sleepy earlier and they wake up earlier. So both of those factors, that decreased perception of that cycling through sleep and the advancement of sleep phase, make you wake up more often during the night. Because if your phase is advanced, you're more likely to wake up at 3 a.m. or 4 a.m. or 5 a.m. earlier than you might have in the past. And if you're having less deep sleep and REM sleep, your sensitivity to pain, to light, to noise, and other things that may interrupt your sleep or needing to go to the bathroom, all of those things increases. So yes, sleep disruption increases primarily for those two reasons, because that cycling is decreased and the deep sleep and REM sleep decreases, and also because that circadian phase advances.
If someone would like for you to address night sweats and what to do about them. They are 4 years post breast cancer and therapy-induced menopause, and 10 months post bone marrow transplant due to therapy-induced AML. And weaning off steroids has helped, but still have them 2 to 3 nights a week.
Yeah, boy, that's a really tough question. So in our breast cancer, one of our most common complaints is night sweats interrupting sleep. And of course, hormonal therapy is not an option when you have breast cancer. To replace estrogen is not an option, because obviously many breast cancer patients are actually on hormonal blocker therapy, which actually induces the night sweats in the first place. And so there are some studies using certain antidepressants that can help with night sweats in that setting of breast cancer in patients who are on hormonal therapy that blocks estrogen in particular. And so we have seen that to some extent being beneficial. I don't know any data about night sweats in acute leukemia, to be honest. I haven't seen any studies on ways to improve that. Obviously, also patients with lymphoma, one of the symptoms is night sweats. So, so that would be, but I have seen some data using some of the tricyclic antidepressants is what they're called, imipramine or amitriptyline are two of the drugs that have been used with some success in that scenario.
Okay. Any suggestions on ways to calm the mind so they are able to fall asleep initially or return to sleep? Counting sheep does not work.
Yeah, I get it. Another fantastic question. I think when I think about that question, it gets to be very individualized what precisely works. I will tell you some of the common things we talk about. One is calming the mind, to me, also suggests some degree of anxiety and worrying, and that can be very hard to overcome. And if you're dealing with stem cell transplant and how it impacts you and how it impacts your family, that can be of course, a considerable source of anxiety and worry. One of the things I ask patients to do is to keep a journal and make lists. The reason for the journal is for them to be able to write down or somehow signal what's important to them, what is disturbing them today, get those out. And then the list is to actually list what they might do the next day to try to address that. Would it be talking to that family member? Would it be talking to your physician? Would it be getting some sort of counsel? Would it be whatever it might be? But making a list of potential solutions and making a plan on how are you going to address those concerns or worries. And when you do that, I think in some ways it gives your brain or your mind permission to relax and wind down, because you have a plan, you've kind of reflected on those issues, and you've given yourself time to do that before you try to fall asleep, so that when you do try to fall asleep, those issues are in some ways, obviously not ended in any way or finished, but at least partially addressed, so that it gives you almost permission to fall asleep and to try to calm down. There's obviously other strategies. There's white noise, there's music, there's aromatherapy, there's different meditational techniques, relaxation techniques. All of those can work. But when I think about calming the mind, a very simple strategy is I think keeping a journal, making a list of sort of your plan for the next day or the next week on how you're going to address some of the things that are worrying you can really be helpful in allowing yourself that permission to sleep that night. And then some of the other strategies, whether it's music, reading, prayer, meditation, structured relaxation techniques, all of those have been found to be useful.
The next question says, I had a transplant 15 years ago and was on maintenance Revlimid for 6 years that caused leg cramps that persist to this day. They wake me up, and it's hard to go back to sleep after I walk around to get rid of the cramps. I take Ambien sometimes to get me back to sleep, and sometimes over-the-counter drugs for leg cramps. Any suggestions?
Yeah, that's a great question. So Revlimid is one of the medications that can cause pretty severe neuropathy and can cause those periodic limb movements of sleep. So I don't know if you've noticed if your sheets are more in disarray than they used to be after you took Revlimid, or if you have a bed partner, if they notice more activity or movement. Those might be signs. And again, that one of the last slides I had is sort of that structured approach we have to doing a physical exam and getting some lab work to try to understand what the causes that might be. So, doing an exam to look for neuropathy, looking if your pain and temperature sensation is the same in your legs as in your upper extremities. That's something your physician may, help be able to assess. And then also sending off some of that lab work, iron studies, B12, folate, to see if there's reversible causes of neuropathy. And then if needed, doing direct treatment for neuropathy. I mean, Ambien is a wonderful thing to try to bring down that alertness that it comes from your movement or your pain or that need to move. But it's not really treating the cause. It's kind of putting a Band-Aid on it. But actually thinking about if there is a neuropathy, being on a pill or medication for neuropathy may help. That may help with the leg cramps, or being on a medication to treat restless legs or limb movement disorder, if that's what was found on a sleep test, may actually help. So I'm talking sort of in general. I mean, I don't know your case specifically, but if I had to approach that set of symptoms that you described, a physical exam, doing appropriate lab tests, maybe doing a sleep test to find out what's causing it, if I can identify a treatable cause, and then actually using medications tailored for that, rather than just trying to suppress your awareness of the symptom with a drug like Ambien.
The next question says, I am getting phlebotomies for iron toxicities. Can iron toxicity cause sleep apnea? Says, I need a CPAP. I'm hoping that after my ferritin, I'm hoping I'm pronouncing that correctly, ferritin gets back to normal, I won't need CPAP anymore.
Well, that's a really good question. I see, I mean, the iron toxicity was severe enough that there was iron deposition, especially in certain areas of the head and neck, and that caused, especially sometimes iron deficiency can cause nerve issues and dysregulate the control of breathing that way. I can kind of see a connection, but I don't think in the literature there's a very clear connection between iron toxicity and sleep apnea and sleep disorder breathing. So I'm not sure that it is the cause. I can kind of see a mechanism for that, but I'll be honest with you, I don't think there exists in the literature something that says that there's a clear connection between iron toxicity and sleep apnea. Or there may be just case reports or something very minimal, but not in a structured way. And so I'm not sure, to be honest with you, it's just correcting the iron toxicity, bringing that ferritin level down. if that will impact your sleep disorder breathing and mean that you won't need to use CPAP. I think if you had your ferritin come down, I would want to retest for sleep apnea if you feel like your symptoms are better and prove that there's actually an improvement in your sleep apnea before I took you off of something for CPAP. The CPAP is really important for sleep apnea, especially if your oxygen levels are low at night, because that can increase your risk of heart attacks and strokes and arrhythmias. And so we don't want to minimize that treatment just because your iron gets better, especially if it's for another reason other than the iron toxicity. So I would be very careful about getting off CPAP for your sleep apnea if your iron gets better without doing some sort of sleep assessment, a sleep test to make sure that your sleep apnea is actually better.
Okay, speaking of sleep apnea, someone would like to know if a stem cell transplant can cause sleep apnea.
Yeah, so there's no evidence in the literature that stem cell transplant can cause sleep apnea. So the causes of sleep apnea are multifactorial and not 100% understood. There's obviously genetic predisposition, and there's also anatomy. Some people just have small airways, or they have a recessed chin, and that just predisposes them. The other two factors that increase the risk of sleep apnea are obesity and age. Actually, the older you are, the more likely to have sleep apnea, and the higher your BMI is, especially over 30, the more likely you are to have sleep apnea. But I'm not aware of stem cell transplant. And that being said, if you're on your stem cell transplant and steroids has been a part of your treatment, and the steroids have made you gain weight, and also cause sometimes the fat deposition with steroid use can be asymmetric. It can actually affect the areas of the airways, or it can cause truncal obesity or cause your face to swell. We call that sort of Cushingoid syndrome. If that's the case, then yes, it's possible, but it's probably more related to the steroid than the stem cell transplant itself.
The next question says, I've been told by nurses that I have, in quotes, central, and then they put in parentheses something, so they are not familiar with the middle word apnea, because my breathing slows so significantly that alarms go off. I was put on 1.5 liters of oxygen in the hospital, but was not continued at home. Are the headaches I get in the middle of the night possibly related to the low blood oxygen?
Yes and yes. So usually what we would call that is there's different types of central sleep apnea. That's the something that we're missing. Central sleep apnea is this syndrome of where we actually, if you can think about it, your brain forgets to, for whatever reason, to tell your muscles of respiration, your diaphragm and your rib muscles, to take a breath, if you can believe that. And we see it in certain conditions such as heart failure, and maybe sometimes after a stroke, or certain brain lesions, including cancer-related brain lesions. And so what happens in central apnea is exactly what the person who asked the question said, that they stop breathing, and probably when they're in the hospital, the nurse saw that the oxygen went low and prescribed oxygen. And I think it would be very important for you to find a sleep doctor, or a doctor who can order a sleep test so that they can actually tell you what you have. Because sometimes just by looking on the oxygen curve in the hospital, you really can't tell whether it is central sleep apnea or obstructive sleep apnea. You really need to do a sleep test to actually know that. And so it will be really important for you to know, just because the nurse witnessed apnea, what is truly the cause of it, so that you can be on the right treatment. Because the treatment for obstructive sleep apnea and central sleep apnea can be different, and therefore you'd want to know what the actual disease process is, so that you can get on the right treatment, and maybe more than just oxygen. Now, I'll just put it this way: if you're wearing oxygen and you have obstructive sleep apnea and your airway closes at night, the oxygen is not going to get into your lungs, so it's not going to do you much good. Whereas for central sleep apnea, because of the way your brain works, oxygen therapy actually sometimes is sufficient to help your brain know when to breathe. because there's these receptors in the body that respond to oxygen and carbon dioxide that actually modulate how you breathe at night or how you breathe during the day, for that matter. And so oxygen can help sometimes reset those modulators in your body that tell you when to take a breath. But if you have obstructive sleep apnea, that's a completely other physiology and a different disease process, and the treatment may be different. That would be more like CPAP. So I think it would be very important for you to get tested with a formal sleep test to know what kind of sleep apnea you have, so that we can make sure that you're actually on the right therapy.
Okay, this is going to have to be our last question. We are running out of time. Someone would like to know, what kind of drug is estazolam?
Yeah, and that is one of these. It falls into that sedative hypnotic. I think you're talking about Lunesta, azopiclone, perhaps. And azopiclone is a long-acting sedative hypnotic. It's kind of like a long-acting Ambien, and it's a wonderful drug for short-term insomnia, but I don't recommend it for long-term use. And just to backtrack a little, when I talked about pharmacological therapy, there are these sedative hypnotic class. The traditional medicines that were used in the past were the benzodiazepines, or drugs like Valium, and you may still see some patients on things like Klonopin or Xanax, those kind of drugs for insomnia. Not the greatest choices, and they actually have the most addictive potential, and they also have the most, so they're most habit forming, and they also have the most daytime drowsiness, and then the ones that are most associated with falls and delirium, especially in the elderly. This non-benzodiazepine sedative hypnotic class, which is like your Ambien and your Lunesta and your Sonata, those are a little bit better on the safety profile, but they're not perfect. They can still cause falls, they can still cause delirium, so you need to be very careful, especially when using it in patients with neurological issues or in the elderly who might be at a fall risk. I don't know, some patients with cancer because they had blood clots are on blood thinners, so you have to be really mindful. You don't want someone to hit their head if they're on a blood thinner. So you do need to be very mindful when you're using these medications, especially in the long term. And so if you are being prescribed this for a long term, and by long term I mean more than 6 months to a year, you may want to ask your physician, are there other options? Is there cognitive behavioral therapy that I could do to see if it's possible to get on some of those medications, get off some of those medications?
Thank you so much for all that wonderful information. On behalf of BMT InfoNet and our partners, I'd like to thank you, Dr. Balachandran, for your very helpful remarks, and thank you, the audience, for your excellent questions. Please contact BMT InfoNet if we can help you in any way. Enjoy the rest of the symposium.